Lepo pozdravljeni. Nadaljujemo drugi del dopoldanskega strokovnega srečanja, ki bo od zdaj naprej bolj zobozdravstveno obarvan. Naslednji predavatelj bo profesor dr. Hrvoje Jurić, ki je diplomiral leta 1995 na stomatološki fakulteti Univerze v Zagrebu in v tem študijskem letu prejel rektorjevo nagrado za najboljšega študenta. Magistrsko delo je zagovarjal leta 1999, specialistični izpit iz pedontologije je opravil leta 2001 in doktoriral leta 2002. Leta 2003 je bil izvoljen v docenta na oddelku za otroško zobozdravstvo na stomatološki fakulteti v Zagrebu, leta 2007 v izrednega profesorja in leta 2012 v rednega profesorja. Doslej je objavil več kot 100 znanstvenih in strokovnih člankov, od tega več kot 30 v SCE. Je soavtor 3 univerzitetnih učbenikov s področja otroškega zobozdravstva, v enem je tudi glavni urednik. Aktivno je sodeloval na več 10 domačih in tujih znanstvenih konferencah. Že več kot 10 let aktivno sodeluje pri stalnem izobraževanju zobozdravnikov in je imel več kot 200 predavanj in delavnic doma in v tujini. Bil je mentor pri 3 doktorskih disertacijah. Je član številnih strokovnih združenj in društev. Od leta 2008 do 2015 je bil predsednik Hrvaškega združenja za otroško in preventivno zobozdravstvo. Od leta 2015 pa predsednik Hrvaškega zobozdravstvenega oziroma stomatološkega združenja in tajnik Hrvaškega združenja za otroško in preventivno zobozdravstvo. Od leta 2014 je predstojnik oddelka za otroško in preventivno zobozdravstvo na stomatološki fakulteti v Zagrebu. Aktivno je sodeloval v različnih raziskovalnih projektih, tako doma kot v tujini, na primer pri poškodbah zob pri otrocih, glede preprečevanja in zdravljenja, epidemiologija karioznih in nekarioznih lezij pri otrocih na Hrvaškem in tako naprej. Glavna interesna področja profesor dr. Hrvoja Jurića so preprečevanje kariesa, mehanično in kemično obvladovanje zobnih oblog, mikrobiologija ustne votline, endodontski posegi pri mlečnih in na novo izraslih stalnih zobeh, poškodbe zob in estetski rekonstruktivni posegi. Danes nam bo profesor Hrvoje Jurić govoril o sodobnem pogledu in vključenosti celotnega tima v obvladovanje in spreminjanje otrokovega vedenja v zobni ordinaciji. Profesor Jurić, izvolite.
Dobar dan, sve vas najsrdačnije pozdravljam.
Velikim veseljem, dobrodošli.
Jako mi je žao što nismo zaista uživo u Portorožu, pogotovo ovako lijepi dan. Možda bi to samo smanjilo broj ljudi u dvorani, ali...
U dvorani ne, a u odmoru bili bi svi, a ne?
To je sigurno, tako da mi je jako žao. Nadam se da će biti prilike još i uživo se podružiti s vama i pokušati podijeliti nekakva iskustva i znanja koje imamo. Tako da vjerujem da će ovakav skup biti zadnji u neko dogledno vrijeme i da će ovo biti početak kraja pandemije.
Ja, mi si tudi želimo tega. Predavanje bo potekalo danes v angleščini, tako da profesor Hrvoje Jurić, izvolite.
Ok.
Videli vašo prezentacijo?
Aha. Jel vidite sad prezentacije?
Vidi se. Še na večji skrin.
Samo malo. Još jednom otvorili. Ovo nema nikakav problem. Ok, just samo sekundicu.
Ni problema, to se dogaja v živo, a ne?
Aha,
to je del tega procesa.
To je tako. Ne znam zašto ga sad ne vidi.
Evo sad će.
Sad će vjerojatno.
To je to.
To je to.
Da.
Evo ga, sad se vidi se sad prezentacija.
Vidi se, perfektno, odlično.
Okay.
The podium is yours.
Well, thank you very much for a nice introduction. Thank you all to share your time with us to try to improve your everyday clinical practice. It's really pleasure for me to be invited, and I hope so that I will fulfill your expectation about the presentation for today. Our subject or title of the presentation is Behavioral Management of the Children in the Pediatric Dentistry Office. And I think so that everyone have a different experience treating the child in the pediatric dentistry office, but I believe that I will share with you my everyday doubts, difficulties, and the troubles which I have when I treat the patient. But one really important thing is when you treat the child and when you have a good communication with the child, you will be awarded with a really honest approach from the child to the pediatric dentistry team, actually, because the team is very important when we treat the child. First of all, I give one definition of the pediatric dentistry. That's a specialistic discipline which deals with preventive, diagnostic, and curative procedures of all possible pathological conditions in the oral cavity and surrounding orofacial structures in the children from the birth to the age of 18 years, which means that we cover a really huge period of time with a lot of changes, from edentulous oral cavity to primary dentition, from mixed dentition to the permanent dentition, and that's a really challenging time for everyone to treat the child in the proper way from the early beginning to the adolescence. Pediatric dentistry is a professional, in this case, very challenging discipline, which covers a huge period of time, The biggest changes we have at this time, we have edentulous teeth, as I mentioned earlier, from edentulous oral cavity to the full permanent dentition. And in this case, we covered a really huge or large number of therapeutical procedures, which include treatment of caries, periodontal diseases, small surgery, intervention. We deals with mineralization disorders, developmental anomalies of the teeth and eruption disorders, dental trauma, work with children with special needs, children with huge anxiety or dental phobia, and that is really challenging for everyone who treat the children. Who do we need in this time? What do we need in this time when we treat such patients? Do we need orthodontist, periodontologist, oral surgeon, pediatric dentist? We need a huge and really knowledgeable, motivated dental team with the dentist and with the assistants. We need you, which are really ready to fulfill all expectations from child and parents when we treat our patient. Some other definitions about the fear and difficulties in the behavior of the child when they come in our office. First of all, the mild form of fear we define like dental fear or normal emotional reaction to an unpleasant external stimulation in the specific situation, which means that dental treatments is always increase the level of adrenaline in our patient, and especially in children. Another more or heavier situation when we have dental fear means a dental anxiety, which means that we have abnormal and irritational fear of a stronger intensity dental procedure accompanied with discomfort and anxiety. And the most difficult situation is when we have a dental phobia, which we can define like culminating and persistent dental fear of a specific object in a specific situation with clearly expressed psychosomatic disturbances like sweating, palpitations, nausea, vomiting, constipation, etc. And that really interferes with the normal daily activities, including dental treatment. When we talk about behavioral management in the dental office, especially when we talk about the behavioral management of child in the dental office, we should know some developmental characteristics of the child, and that means that the developmental characteristics for every age in the childhood means that we should know what is really the main or the most important skills for every child, and that we have child age 2 years or a little bit more. They, from the intellectual development, they can complete sentences with 3 to 4 words. She or he can create a group of toys, can name 5 body parts. And from the manual motoric skills, it's the pattering, he throws the ball and can dresses and take off mostly on his own. And afterwards, around 3 years, we have a little bit increase of intellectual development and count things. His age, she knows his age and gender. From manual and motoric skills, that puts the shoes without help, rides the tricycle, she or he can draw the cycles. And from psychological needs, that when we have the child of 3 years of age in the office, they need a maternal presence, especially during the time of stress, and the dental treatment in this case is really time of stress for this child. Fear of separation and visual fear. Therefore, we should adapt our approach to the child at this age, and we will see during the clinical cases and some other definitions how we can treat our child at age of 3. Age of 4, they have more development of the intellectual development, means recognize colors, tells a story. From the manual motoric skills, she dresses without supervisions, balance on one leg or draw crosses and squares. And from the psychological needs, in this age, we can find a lot of children which are really stubborn or sometimes aggressive. They try to verbalize all feelings they have at the moment, and that can be also really helpful to know and really helpful to adapt our treatment. From the developmental characteristics at 5 years of age, they have increase in the intellectual development, as you can see, ask for the meaning of the words. From the manual motoric skills, they jumps on the one leg, draws geometric shapes, triangles. And from the psychological needs, it needs a parent for a treatment. And this is the really huge change in my professional life. When I started 20 years ago at the Department of Pediatric Dentistry, we don't have too many parents in the office. Nowadays, we have almost all patients treated in the presence of the parents, which help us, and we will show and explain during the clinical cases how we treat our patients. Nowadays, at the age from 6 to 12, it's ready for school, it's logical, it have logical thinkings. From the manual motoric skills, then we have the spine is essential for proper posture, and many orthodontical researches and knowledge know today that the posture is also really important for the development of the right occlusion or normal occlusion, and from the psychological aspect, they get a sense of accomplishments, responsibility for the action, sense for good and bad, and try to analyze outside from the family certain standards and values. And in this case, when we have a child at this age between 6 and 12, they have also tasks, and they fulfill some tasks and try to be competitive. She or he can be hyperactive, measuring with the peers, parental involvement in the school and social life, healthy lifestyle, encouraging reading, consistent, explicit, and firm rules that shape behavior and shape personality, and oral health. It's really, really important to transfer the right information from the parents to the child. That eruption of permanent teeth means that we should save or prevent any pathological processes, first of all, caries at the permanent teeth, because they don't get any replacement afterwards. We have primary dentition and get a healthy permanent teeth, but after this second dentition, we don't have any chance except the prosthodontic treatment and bridges, implants, and etc. Motivation for brushing, use of dental floss, explain to the importance of the permanent teeth health and what they mean, what means those teeth for the whole of the life, for whole of the rest of the life for the child. Those clips explain a lot of difficulties which we have when we treat the child with. I think that the most challenging issue for our pediatric dentist or person or dentist who treated the child is that we treat two patients in the same moment. We treat the child, and secondly, we treat also the parent. As you can see here, it's not very supporting, but the job is done at the end of the day, and we should balance between those two persons, in this case, the parent and the child. Assessment of the child behavior, we have really different scales for assessing the child's behavior and feelings in the dental office, like Frankel behavior scale, Wright behavior scale, Wenham picture test, and they're really useful. We don't need to know those really in the details, but we should also use some other scales for the diagnostics and evaluation of the dental or medical fear, and these scales like CDIS or SFSS dental subscale, child fear survey scale, means that this is most used diagnostic tests for scientific studies about dental fear, and some others like short dental anxiety inventory, child medical fear questionnaires can be very helpful when we try to give some evidence base about dental fear, and it's very often used in some clinical scientific studies. This is the Wenham's pictures test, and it's really good to use in age between 4 and 10. Then child can find his feeling in this test, picture test, really easily, and then you can see how the child feels before they come to the office, and when they are in the office, we do 2 testings before they enter in the office and in the office. And this is really helpful because the child can give to you information about the feelings and how they feel before and during the treatment and after the treatment. As you can see, Buchanan and Niven give the facial imaging scale almost 20 years ago, and the age of social media, smartphones and everything, the MOAs were used much more before, much time before that we use the social media and MOEs in the everyday communication. And it's really, really easy to know today because the child from the early age understand those pictures, and you can really easily communicate with them about the feelings about dental treatment. Frankel behavioral scale give us some information about the attitude of child to the dental office, and you can see clearly negative, it's value 1, it's slightly negative, slightly positive, and clearly positive. And it's really challenging when we give the value of 1 or 2 for our patient, but it's really challenging also, and we try to do all our best in this case to change the attitude, change the feelings about dental treatment, and that is our everyday practice when we treat child in the dental office. Behavior categories by right, it's a really old one, it's a really really rough, but it can be really helpful for clinicians for everyday practice, because we really easily and clearly recognize cooperative patient afterwards. Lack of cooperative ability give us a lot of chance to change the attitude and change the behavior of the child in the dental office. And potential cooperative behavior, it's really a good beginning of the treatment, because it depends on our approach. We can potential cooperative behavior really easily change to cooperative. Forms of potential cooperative child behavior, it's uncontrolled, it's sometimes really difficult, but we have some behavioral management approach to change the uncontrolled patient with the help of parents. We have also defend our stubborn child, afraid, cowardly, tense, cooperative, which is good start because we can increase the good attitude and understanding what we want from the child. And tense cooperative is much easier to treat. Weepy is sometimes really difficult. They crying without any good reason, and sometimes it's really hard task to change this approach or this way of behave of child when they weeps or when they cry without any good reason. And stoic without any complaints, it's sometimes also warning sign for us, because the stoic behavior means in many cases that child is not treated very well from the family, and they have a really maybe a difficult childhood with difficult grown-ups, because they have a really tough way of grow up because the parents are not really emotionally enough. They don't treat them emotionally enough in the right way. Parents' attitudes toward the child, it's a very protective, and that could be also challenging for us. Extensively lenient, extensively authoritative. That means also really difficult for the child, and extensively authoritative attitude to the child from the parents cause very often the stoic behavior of the child in the office, and insensitive, rejective behavior. That means really also difficult for the child, first of all, and it's really difficult for us because we don't get the really good communication with the parents and with the child in this case, because this child is mostly talks really less, and really it's really difficult to approach to those child who have insensitive, rejective behavior or treatment from the parents. What is important for successful control of child behavior in the dental office? We should be a skilled observer and assessor to the child's parents' behavior. We should precise the term, the type of child behavior, give some working diagnosis, master the skill of communication with the child appropriate to his age, note the specific of the child behavior according to the age, and master behavior control procedure. As you can see from this introducing in the lecture, that we have a lot of different tests and scales to assess the level of fear or attitude to the dental treatment from the child, and we should also know how to control the behavior procedures. And this is the first clinical case, really specific situation, because the biggest problem for the parents is that these central and lateral incisors doesn't erupt for 3 or 4 months, and they don't see any other problem. When you look a little bit better, then you can see that the oral hygiene is really on the low level. And the second thing is that no one recognized that we have some orthodontical problem, and that we can really easily try to, with interceptive orthodontic procedure, try to treat this patient. But we should also communicate in this case, how to satisfy the parents, how convince them that you are really knowledgeable and full of goodwill to treat the child. And this is the good beginning to introduce to the child the local anesthesia. And after the local anesthesia, we do the first incision, and afterwards we do the second incision, and we have in this case we see that the central and lateral incisors are really close. We deliver actually the central and lateral incisor. The parents are really happy in this case because everything is fine. And now you get a chance to convince them how knowledgeable you are, how good will you have to treat the patient, and you can now introduce the oral hygiene in the right way. You can now introduce some interceptive or early orthodontical treatment, and that could be really a good beginning for communications and right dental treatment for this child. It is really important, as I mentioned earlier, that we have good dental team in the office. Dental team means also our assistant or the nurse in the office, and we should have also replacement dictionary for like a drill is a brush, dental probe is a tooth counter, anesthetic is tooth sleeping water, curious is a brown spots, a matrix band is a tooth fence, impression material pudding or ice cream, or radiograph is a picture of the tooth, and that it's really helpful that we don't produce too much fear or confuse in the head of the young child, who is very good listening everything what we talk during the treatment. About the communication procedures, fear denial is a really wrong action. If you said you are big enough to not be afraid, that's really wrong approach to encourage the child, and we should change our way of thinking. In this case, we should encourage them and use another behavior procedures for motivating the child in the right way to accept our plan for dental treatment. Voice control is really important. Voice control is important in this case because gaining a child's attention in this case it is often more important for a child how you something said than what you said, and that's really important. And we should use different tone of the voice from mild to the firm to explain them when we are okay with his behavior, and when we need a little bit more attention and a little bit more concentration and cooperation during the dental treatment. What could be a serious mistake in communication? Seeking for permission to provide the treatment, it's a really huge mistake. If you give them chance, do you want to treat the tooth, or do you don't want to treat the tooth? In many cases, you give the answer that no one wants to get the tooth treatment or dental treatment, and especially in child, that it's confusing the child, and therefore we should communicate much more directly to the child and give them all needed information and what we expect from him during the treatment. This is one trauma case, really difficult and very weird, a fracture of the tooth with a really deep palatal impact of the fracture line. Afterwards, we do the root canal treatment and we restore the tooth. But she came back 3 or 4 years after that because we have some changes in the color of the central incisor, and nothing else was important in this case. No one takes care about some potential orthodontical treatment, etc. And we decided to retreat this tooth with the bleaching. We changed the restoration of the crown fracture and improved the oral hygiene, as you can see here. And now it's a good time and good timing for explain them that they need also orthodontical treatment, and afterwards this patient accepted the orthodontical treatment, and that is really good approach to change the attitude to the dental treatment. And when we start from here, from this colored tooth with the bad oral hygiene, and now with the improved oral hygiene and restoration and improvement in the tooth color, then we can get more reliability and we convince the patient much easier to go to the orthodontist and also do the orthodontical treatment, which is really important for this patient and his future life. Good communication with the child, key for good behavioral management is task for the dentist. Ability for active communication with the child at the age of 2. Before that, it's really difficult, but at the age of 2, we can have some active communication with the child. And secondly, We should have also very precise communication with the parents, explain them that they should be involved also in providing the oral hygiene. When you communicate with the parents, in many cases we get information how this 4-year-old child is perfectly brushing teeth by themselves. That's not possible because the manual skills at the 4-year-old child is not good enough to brush teeth, and then therefore it's a really good argument that we should include the parents also in the providing the oral hygiene. Secondly, the communication should be verbal, visual, tactile, and as you can see on this picture in the right corner, the communication is done very well. You have smiling child following you with the eyes, and everything means much better in this situation. After some trauma cases, the patient come to you because even they are not anymore children, because they have really good communications with you. You convince them that you are the best possible, that you give them best possible treatment. And in this case, we have some difficulties with the late mistakes, we can say, after the trauma cases. And you can see here the inflammation of the soft tissue, which is caused mostly because of this empty space between the filling and the root canal filling. And we explain them that we can improve this with some prosthodontic treatment. We put glass fiber post inside, cemented by adhesive composite material, as you can see here, with gravia core. And afterwards we do some small intervention of the soft tissue, and with long temporization we get healing of the soft tissue. We reconstruct also some caries here, and afterwards we have final result, and our patients going out from our office once again very happy, and with now really nice restorative treatment, with fixed prosthodontic restoration, and with composite restoration on the left upper incisor. What means a good communication with the child? Mostly we have this so-called communication triangle, which is consisted in the middle is for sure always the child. Sorry. Okay. Sorry. And the communication triangle is consisted from 3 parts. It's always in the middle is the child. From one hand side is the parents, and the another hand side is a dental team, which is consisted from dentist and from the dental assistant. Dental assistant could be really helpful for all of us also in many cases. This is one case of really severe trauma. As you can see here, it's treated in the emergency care with some splints and some injuries of the lower jaw and lower lip. And we decided to replace this thick wire with a little bit thinner, which is more physiological for this case. We do some repositioning of the central incisor. This is young fellow in the age of 15, I think so, this time when they are injured. And they come 5 or 6 years afterwards. It's not anymore actually regularly patient of pediatric dentistry department in our university, but as I said earlier, they are really addicted somehow on you and on your treatment, and therefore they always coming back after you treat these trauma cases. As you can see, we have some internal resorption here. We try to treat this internal resorption with cleaning of the cavity, and we do some intervention of the soft tissue, and we rebuild once again this root with the glass ionomer cement in this case. And through the glass ionomer cements, we do preparation for the posts. We do the adhesive cementation of the post inside. We do the restoration with composite materials of the crowns of the central incisors. And as you can see here, we have once again a little bit improved this situation, and we lost finally those two tooths 9 or 10 years after the injury, in the age of 24 and 25, and that was a really good treatment plan and a good treatment outcome at the end of the day, because they have now a chance to do some implantology reconstruction or fixed orthodontics reconstruction. And this was also really the last visit before the extraction. They come once again to our office and convince us that we do the good job, and they want a final opinion also from us, what is the best way for the final treatment of those central incisors. In many cases today, we saw our patient with the permanent dentition with this discoloration, and this discoloration in the incisors means that we have in many cases destruction or chipping fractures on the first permanent molar, because this in many cases this is the diagnosis of molar incisor hypomineralization. And molar incisor hypomineralization, instead of this discoloration and not really high aesthetic look of these central incisors and laterals, the most important thing is that we have loss of vertical dimensions in the molars, because we have chipping fractures and loss of the cusps of the first permanent molar, and we try to remineralize those teeth and keep them in the mouth as long as possible using a glass ionomer cements like Equia Forte or Triage, and try to remineralize this hypomineralized first permanent molar, and we try to get the increase in vertical dimensions with the eruption of second molar, which in most cases are not involved in the syndrome of molar incisor hypomineralization. As you can see here, and the upper first permanent molars, we have also some defects, and these chipping fractures are really difficult to treat, especially with composite in this time. And in these cases, when immediately after erupting of those teeth, we treat it with glass ionomers to try to preserve and remineralize this demineralized enamel and dent. What is the child behavior control technique? The most important and the most used technique is tell, show, do. It's really important to communicate with the child, to explain them what we try to do, show them how and with which and with which instrument you will do it, and for sure at the end of our story we try to do it in the right way. The reinforcement is really important thing, and we reinforce the good attitude to the child. We give them good grades, or we are really happy that we achieved something, and then we explain them that they get new stars if we do some Peter Fisher sealings, that they get the new stars on the teeth, which are preventing any difficulties or troubles afterwards. Modeling is really good. Modeling is really good approach. Modeling means that siblings or some other child from the dental office is model in the good attitude and good behavior during the treatment for the other child. That means that is really easy to do it in our department, because we treat 2 or 3 or 4 kids in the same time, in the same moment, and it's really good to show the other child which comes with fear, or it's a first experience in the dental office, to see how the other child receive the treatment in the dental office. This sensibilization is really nice approach. Also, we do some easy stuff. We just brush the teeth with a slow hand piece. Afterwards, we do the fluoridation, and afterwards we finish the first visit. And in the next step, we do some small cavity, maybe some enamel preparation, which don't cause any pain for the child, and therefore it's really good to increase the treatment plan with how they are able to receive our dental treatment. And in this case, desensibilization is really good. And methods of physical restraint, or so-called immersion, it's nowadays not very recommended, because it's not very good for the future of behavior for the future behavior of the child in the office. Important step in the behavior control, as I can see, we can say that's a way of desensibilization. First, check up on prophylaxis with the slow handpiece and prophylactic paste, Pitt and Fisher sealing, and topical fluoridation. At the next visit, small preparation and some small fillings, like class 1, really shallow. Afterwards, local anesthesia. It's really important to use as much as possible local anesthesia in the child, because they get a completely different information if we treat child without any pain. If they get the local anesthesia, we explain them that he will get some sleeping water for the tooth, and afterwards the communication is much easier, because we treat the patient without pain. And at the end of the desensibilization, we can use mandibular anesthesia, extensive preparation, or extraction, or something like that. It's very bad if we start with some extraction or some emergency treatments like trepanation or something like that as a first visit in our office. Here we have some one extrusion, one another extrusion luxation, repositioning afterwards. There's also some young fellow in the age of 14 or something like that. And we have some difficulties with the communication afterwards. They didn't show anymore in our office, and they come 2 or 3 years later, again with the broken tooth, and this is completely indication for the extraction of the remaining root. But we try to save the tooth anyway. We do some intervention on the root. We rebuild the root with the glass ionomer cements here, do the endodontical treatment afterwards, and produce some post and core indirectly. with indirect method and with gold. Afterwards, we do the temporarization with the temporary crown preformed, and after the healing of the soft tissue, we have some metal fused ceramic crown cemented on this root. It's not really a treatment for forever, but we produce something which is really acceptable for this young boy, and we believe that we buy some years without any complicated dental treatment before we lost this central incisor. And the one big question is always when we have some difficulties with the first permanent molar, which are in a which have a really big problem with extensive carious lesion, which involved also pulp. Then we have a possible trouble in the communication, because that's really young children in the age of 7 or 8, which are really which the endodontical treatment is really difficult for them, and they have no dental experience in such an extensive way. As you can see here, we have undeveloped root of the first permanent molar and a really huge destruction of this crown, and this is really questionable about the future reconstruction. And thanks God for the modern diagnostics and good orthopantomography. You can see here the third molar here, and in many cases with such infamous bad prognosis for this teeth, it should be extracted at the right time. What means right time? That means that we have developed second molar, the full crown, that we have also the knowledge that we have also the third molar, and the latest time for extraction of the first permanent molar is the formation of furcation at first third of the root of the second molar. If we do the treatment with too long waiting, then we have such problems like you see here. We have tipping here, and we have some huge periapical lesions in the right lower first molar, and then we have a lot of difficulties to treat it in the right way. Just we don't make a right decision at the moment. As you can see here, that's also pulp involvement. We can see here, and that's the latest time to decide to extract the tooth. And it's a formation of the first third of the second molar. And after a year and a half, we have eruption of the second molar when we extracted the first molar in the maxilla. More than 90%, we have self-healing without any endodontical treatment in these patients, which we decided to extract the first permanent molar. And same situation here. We have also this third molars here, the crown, the mineralization of the crown, it started already, and at its latest time to, as you can see here, we have furcation and the formation of the first third of the root. That means at the age of 9 or 10, but even it's better than we start at the time. As you can see here, we have still difficulties with the oral hygiene, with the inflammation of marginal gingiva and gingivitis, but we restore all these cavities. We do this with the glass ionomer cements to improve the concentration of remineralization ions in these teeth, and we have also we do also the Pitt and Fisher sealings of the first and second premolar. And you can see here how we have the eruption of the second molars instead of in the place of first molars without any orthodontical treatment. Now we create situation that we can also do some good orthodontic treatment to resolve all this situation when we have some lack of the space in the lower jaw, and also regulated the teeth in the upper jaw with the fixed orthodontic treatment. At the end, for the conclusion, to be a good pediatric dentist, we should have a lot of motivation. First of all, we should have a lot of empathy and understanding for all our patients and for all parents too, because as I said earlier, we treat two patients in the same time. That's a child and the parent. Knowledge should be enormous because we cover a really huge amount of different dental procedures, from restorative dentistry in primary teeth, endodontics of primary teeth, restorative in permanent teeth, some interceptive orthodontics. We should also treat the patient with special need under general anesthesia, and knowledge should be really, really huge. We should have some talents to be a good pediatric dentist. We should have good clinical skills and should be committed. Commitment is really, really important, and if you are committed to your patients, that means that you can give more than 100% of your knowledge and skills in the moment when the patient needs. If you have some doubts about treatments or decision making, please don't do nothing what you do not want to do to your child, and you will always do a right indication and choose the right dental procedure. And one more important thing is that everyone around you see the success, but this 9 from 10 parts, it's below the success and below the waterline. It's a hard work, risk, late night struggles, discipline, courage, doubts, criticism, disappointments, sacrifices, and everything. And I think so that the pediatric dentists are really, really ready to do everything to achieve this success. And at the end of the day, one really important thing is, and I want to thank very much to our team at our department. The commitment and the motivations are really important in this case. Smiling faces, good team who push you forward when you lose some strength and ambition. It's really, really important. That's our students, which also do some efforts to make our waiting room more comfortable for the children, and we always try to improve our behavioral management and behavior control as much as possible when we put some good informations, goodwill, and happy smiling faces for every patient which come to our office. And once again, when I want to thank the team, that's my house team, which is also very important because they push me also forward when I lose the energy, and that is really important that we start from this picture here 15 years ago, and nowadays we are here, and thank to my family too. Thank you very much for your kind attention. If you have any question, please, I'm ready to answer now if I know. If not, if you have some delay with the thinkings and doubts, please use my email and I will try to answer as soon as possible.
Thank you, Professor Jurić. Thank you for a transparent, concise, and clear presentation, and actually for some practical hints and solutions. I do see some questions, 2 questions actually in the chat. Can you see them? One is in Croatian language, one is in English. Can you read them? And maybe you can just directly answer them.
I just closed the sharing.
One is from Primari Leskošek.
Sorry. Just closed the sharing. Okay, in the chat. Where is the chat? Super, ok, pitanje. U Sloveniji neki roditelji kažu svoje djeci, ako ne budeš pravo zube i jeo previše slatkica, odvišćemo te kod zubara. I on će ti izvaditi sve zube i bolje će. Tako smo mi već u početku, u lošem startu, kad nas dete vidi u ambulanti, ima takvih slučajeva i kod vas u Hrvatskoj. Should we translate the question or
No, it's not necessary.
It's not
Just
necessary.
directly answer, please.
We have a really strong campaign in Croatia about the importance of improving the oral health in the whole population. And lucky me, I didn't heard such story maybe 4, 5, 6 years ago. I think that this approach is little bit, it's finally vanished from our society. And with a big smile, I can say I didn't heard such story at least 5 or 6 years in my practice.
Right.
And then I see every week between 70 and 100 patients. Most difficult because we work at the Department of Pediatric Dentistry at the University Clinic, and those patients all are referred to us with very difficult cases, from clinically to psychologically. And lucky me, I didn't hear this story for many years. And I think so that the preventive activities in Croatia give some results in the end of the day.
Obviously, we should do something more as a society as a whole.
Yes.
Okay, the second question.
Yes, I don't ask a child if he wants the treatment, but I always ask if he is ready to start, if I'm allowed to proceed. It is a big game changer if you give a child the feeling of control of the procedure. I always give them a sign for stop, raise the hand, so they get a feeling they are in control. That's a great approach. I just can't clap with my hands for this approach, because when you give to the child feeling that they have control of the treatment, that's the most important thing, that you can control his behavior. And this is really nice clinical example how you can very easy, with the empathy, with the understanding of the child's fear and everything, can make the situation more comfortable for all participants, for the child and for the dentist. And just a big hug and claps for Urška Savli, and how she explained easy, and how he modeling this attitude in the dental child's attitude in the dental office, because every one of us want to have control in any situation, and therefore I think so that's a really nice clinical example.
Okay.
I do the same. I do the same, and it's a really nice experience.
Once again, thank you very much, Professor Jurić. We were pleased that you have been a guest at our meeting. I'm afraid there is no time for another question, but I think there is no one in the chat, so thank you.
Thank you. See you.
Bye.
Bye.